It is my honor to introduce our next plenary, a conversation with the U.S. Surgeon General. The conversation is going to be hosted by the CEO of the American Medical Association, Dr. James Madara. So let me turn it over to Dr. Madara and our U.S. Surgeon General. Thank you.
Well, thank you, Michael, and hello, all. And also thanks for everyone for joining us. What I'm pretty sure is going to be a really interesting and insightful conversation with our U.S. Surgeon General, Dr. Vivek Murthy. Dr. Murthy is a highly respected physician. He's a researcher, he's an entrepreneur, a thought leader on medical practice. And Dr. Murthy has served as America's doctor now under 2 administrations. In the Obama White House, where he helped lead our nation's response to Ebola and Zika outbreaks, and now under President Biden, where he is helping lead our country out of the grip of COVID-19. Dr. Murthy is one of the most trusted voices on healthcare today, and he's keenly aware of the emotional, the physical, the mental toll of this pandemic on physicians and our entire healthcare workforce. 18 months into this pandemic now, and with cases recently spiking across the West and the South, we're a health system that remains under siege in several areas of the country. Dr. Murthy, it's a pleasure to speak with you at such an urgent time for healthcare and healthcare workers in our country and around the world. And we'll get right to the obvious topic, COVID. But if we have a moment toward the end, we'll probe a personal question related to how does it feel to be Surgeon General the second time around? That you agreed to do this again must mean that the first taste was pretty good. So pivoting back to COVID, Dr. Murthy, where are we in our federal response to COVID-19? And where should we be focusing our attention right now?
Well, Jim, let me just say how happy I am to be here with all of you. Thank you for having me. And I'm just glad we're spending this time together on a topic that I know a lot of us care deeply about, which is how to make sure we are investing in and supporting the well-being of our clinicians across the country. And I should also just say I'm very informal, so please feel free to call me Vivek. And if it's okay with you, I'll call you Jim, but we can
preferred.
Just be friends, yeah, and informal here. So a couple of things I'd say just in terms of where we are on COVID. Obviously we have been at this a long time as a country. And I think most of all about our colleagues in medicine who have been on the front lines for so much of the last 18, 19 months, dealing with the pandemic that has had so much unknowns to it. And I first just want to just appreciate all of our colleagues out there who are on the front lines, who have done so much, and often putting your own health and the well-being of your families on the line in order to provide care to others. As Jim mentioned, I've been privileged to wear a number of different hats during my career, and I'm incredibly grateful for the opportunities I've had. But the title that I'm most proud to have, the group that I'm most proud to be a part of, is the title of physician and the ability to an opportunity to be a part of the medical profession. Because I so deeply admire and respect our colleagues for what brought them to this work in the first place, the desire to serve, a desire to heal, a desire to reduce suffering, and a commitment to doing that, even in extraordinarily difficult times. And so I just have felt an immense sense of pride at a profession, and just I'm so grateful to be a part of it. I do think that we are in a better place now than we were a year ago when it comes to COVID-19. So let's talk about what's working well, and let's talk about what's still left to do. Of course, the obvious one is that we have vaccines now, which we didn't have last year at this time. That has really been a game changer. Even though we're in the throes of a Delta wave, even though we are still seeing an extraordinary number of cases and hospitalizations from COVID-19 today, the estimates are that we have saved well over 100,000 lives because of vaccinations, and potentially much more than that. We have prevented hundreds of thousands of hospitalizations because of vaccinations. The fact that we were able to develop these as a country, as a world, and rigorously test them through clinical trials and put them through the FDA process and get them out to now more than 213 million people who have at least one dose of the vaccine in the US. This is an extraordinary testament to science, to clinicians, and to the power of what communities can do when they come together for common purpose. It's been a really extraordinary effort. The other thing that I'm grateful for is that unlike the very beginning of this pandemic, we do have more in the way of therapeutics that are helpful, right? We know now that dexamethasone can be helpful. We have remdesivir as a tool. Very importantly, we have monoclonal antibodies, which markedly reduce the likelihood of hospitalization and death if given early during the disease course. These are powerful, these are helpful. And just recently, we heard from one of the companies about molnupiravir, an antiviral, oral antiviral that had some promising initial trial results with a 50% reduction as reported by the company in hospitalizations and death. Obviously, this needs to go through a rigorous process. We all have to have evaluation of the FDA. All of us have to see the data as well and rigorously evaluate it ourselves. But we are making progress when it comes to therapeutics. And finally, I would say, in terms of the good side, we also have a much better sense of how to prevent the spread of the virus. We've learned a lot about just how incredibly important ventilation is and about the dramatically reduced risk in outdoor settings. We've learned about the importance of investing in better ventilation in schools and have put forth now billions of dollars through the American Rescue Plan for schools to make changes, not just to ventilation, but also to do regular testing and to invest in PPE like masks to help keep our schools safer. So all of that accrues on the positive side of the ledger. And I will just say on a personal note, it's felt hopeful to me, especially in the early parts of this pandemic, to see many people in the public recognizing publicly the role that clinicians were playing and the sacrifices that they were making. I do think that most of the public is not aware on a daily basis of what our doctors and nurses and health professionals do day in and day out, the sacrifices they make. I feel like the pandemic highlighted that for the public in a way that was very important. But there is more work we have to do, and that's absolutely clear. We still have tens of millions, nearly 70 million people in the country who are still not vaccinated. We know they are vulnerable, especially in the face of the most highly transmissible version of COVID that we have, and that's the Delta variant. We also have, I think, what I think of as the invisible costs of the pandemic that we have only, I think, scratched the surface on as a country in addressing. And those include the challenges with mental health that have accrued to the broader population as a result of COVID-19, with increased rates of anxiety and depression and loneliness among many. I also worry in particular about what's happened to our clinicians. Yes, they have been absolute heroes, but that's come at a cost. We already knew, and everyone on this call likely has been steeped in the data around burnout having been a problem long before the pandemic. The pandemic has made the situation worse. And the question that we have to ask ourselves as a country is, are we willing to finally step up and do something significant about it, to lay out a national agenda for addressing clinician well-being, making the investments in changing not just the individual supports that clinicians have, but really the systems that generate so many of the stressors and drain so much of the energy and well-being of our clinicians. So this is a time where I think we have an opportunity, but also an obligation to address some of these deeper challenges around clinician well-being, mental health. And I'm eager to, those are areas actually where my office has decided to focus on, or those are going to be key priorities for me, because I just don't think we can let this moment pass without doing right, especially by the clinicians who have been caring for so many people during this pandemic.
Well, Vivek, exactly as you point out, the physician burnout was a serious problem even before the pandemic. And are there specific steps at the federal level that you can imagine taking sequentially to relieve this burden?
Well, absolutely. And I will say just on this front that, as well, Jim, and I know that the AMA and Christine Sinsky and others have mentioned such important leaders on this issue over the last several years. But we know that in order to address burnout, that this isn't about one organization or one sector acting. We all have to act together. Government has got to play an important role here. Healthcare systems have an important role to play. We know educational institutions, training institutions have an important role they can play. And I actually think there's an important role also for policymakers and the public, and we can talk about all of these. But on the federal side, I think a few things would be helpful. I think one of the places government has a unique sort of opportunity and power really is to highlight an issue as critical to the general public and to lay out a national strategy around it. And I think that's a place where the federal government could make a real difference. I think the second place where the government, as one of the most powerful payers in the system, can have a really important role is in thinking about what we can do to streamline and reduce some of the administrative challenge and burden that too often falls on our clinicians. I think there's an important role the federal government can play on the research side to invest in deepening our understanding of what is driving burnout, but also what is working to help solve it. And then finally, there are investments on scaling up solutions, right? We know that far too often what happens in our country and public health in general is that there are programs that work, but they never get funded, they never get scaled up, right? We saw this a lot and I continue to see it actually when it comes to substance use disorders, where we have school-based programs, for example, like the Good Behavior Games Project and others, which are evidence-based programs that work to reduce the likelihood that kids develop substance use disorders down the line. And some of them are incredibly cost-effective, like the Good Behavior Games, like return $64 for every $1 you spend in terms of reduced healthcare costs, economic productivity gains. Yet it's not invested in or scaled up. This is a place where government can play a powerful role in terms of investment to scale solutions. But I think the bottom line with all of this, though, Jim, is that we no longer, I think, can assume that solely focusing on equipping individual physicians with individual tools is going to be the solution to burnout. This is not just about enrolling physicians in a CME around self-care, that they take for 3 days and then somehow they're certified and they don't have burnout problems anymore. The problem is so much more systemic and it's deeper than that. So this is a place again where I think government has a critical role. The final thing I'll say about government is government can be an important convener as well, and to bring the right people together, the right sectors together to commit to creating the changes, both the systemic and process changes, but also the cultural changes that need to take place in our institutions is going to be extraordinarily difficult. All of this, Jim, I think cannot happen sustainably without us bringing the public in. And I don't mean the broader healthcare profession, I mean the general public outside of healthcare. Because I don't think, Jim, that people fully appreciate how the problem of clinician burnout is already impacting the care that they're getting or not getting. As we know that when clinicians drop out of the workforce, it's not just that there are fewer people to care for COVID, patients in hospitals, but our ability to provide primary care, hospital-based care for other conditions across the board also is compromised. And I just think that there is so much more we need to do to help the public understand why clinician well-being is not just an issue for clinicians, it is a national priority, and it has to be treated with the urgency that it really deserves.
Well, thanks, Vivek. It's great to hear because the physician community, the American Medical Association, National Academy of Medicine view this as a pressing problem. And just for the reasons you mentioned, it's a systems engineering problem. It's not a matter of just building up more resilience in a population that already has a high level of resilience. You probably are aware of a study that's been highly cited that we did collaboratively with the Dartmouth Institute, multi-market, where physicians spend 2 hours doing administrative work now for every hour they spend face-to-face with patients. And we know that intrinsic motivator is that face time with patients and driving home and feeling that you had time to do a really good job for the health of those you take care of. So with that in mind,
and Jim, could I actually just say one thing about that? Because what you brought up is such a critical and fundamental point that we need to make sure every policymaker and member of the public understands as well, which is that I don't know any doctor that went into the profession thinking that they can't wait to spend more time charting, more time in front of a screen. This is not what drives us is the time with patients, is the efforts that we spend contributing to healing. At times when I'm sitting in my office, in the office of the Surgeon General, and I reflect often on my experiences with patients that still continues to this day to inform how I think about how we communicate with the public, how we decide on what issues to address. But the things I'm thinking about are the conversations I had with patients, right? It's those face-to-face interactions, those phone calls during moments of uncertainty and doubt where we had to navigate it together. That is not only the bread and butter of medicine in an emotional sense, but that's actually what leads to the best outcomes is when clinicians have that time with patients. And I just think there is more work we have to do to make this clear to policymakers and the public. But I just want to underscore what you said, because that couldn't be a more clear illustration of the problem that we have in the current system of medicine that we're operating in.
Well, the physician community would love to work with you and the federal government toward this end. You know, it's as you know well, physicians and all healthcare workers, rose to that tremendous challenge at the beginning of 2020. Saw that first wave only to see cases rising again in the next wave, and the wave after that, hospitals in some area having to again postpone routine procedures. So one of the questions is, since this was a problem prior to the pandemic and has been exacerbated by the pandemic, what do you see as the timeline of making any progress on this together?
Well, it's a really important question. And I do think one of the silver linings, if you will, of this incredibly painful pandemic is I do think that it has highlighted for both policymakers and the public some of the urgency around addressing clinician well-being. Now, there has already been funding that has been provided in the American Rescue Plan to help support efforts to address clinician well-being. That is certainly a step in the right direction. We know that there's obviously more that has to be done, but the episodes of burnout and suicide that clinicians that were highlighted and covered widely in the press in the spring of 2020, with Lorna Breen and with others, this also helped to drive, I think, a lot of momentum among legislators to say, hey, you know what, we've got to do more than just pay sort of a verbal, sort of praise, if you will, or support to clinicians. We've got to put material support behind this. So in the American Rescue Plan, just as an example, there was about $103 million in funding, like over a 3-year period, that was allocated to reduce burnout and promote mental health, among the healthcare workforce. And this is also a priority not just for the CDC, which is certainly taking the lead on some of this work, but also for NIOSH, the National Institute for Occupational Safety and Health, which has been working on also putting together data, guidance, and resources to address work-related stress and mental health care among healthcare workers. But as I mentioned in the beginning, though, there's a lot more that we have to do. And so one of the things that my office is working on is building a broader strategy here that we need to use as a country to address clinician well-being, one that will have a role undoubtedly for government, building on some of the work that's already been done so far and the funding that's been provided through the ARP, but that also recognizes that the private sector and in our healthcare systems, training institutions in particular, have a really important role to play here. And so part of this is work we are actually engaged in doing right now. We started this work shortly after I was confirmed as Surgeon General in the late spring, and we will continue to move this forward, working with partners like the National Academies of Medicine, ACGME, and others. So we will continue this work, but all this is to say, I feel a great deal of sense of urgency around this. I think about young medical students who are coming into the profession right now. I think about residents who are training, who are looking back at the last 18 months, and then looking ahead at the time, at what may come, and asking themselves, did I make the right choice here? Do I want to stay in this profession? Is it going to potentially get any better? Or are we going to continue to suffer in terms of our mental health and emotional well-being? And I want us to be able to say, beyond a shadow of a doubt, to those medical students and residents that we are committed to making it better, that we are standing with you, that we are making the right investments, but that medicine is still one of the best fields to go into. And I believe this with my heart, right? This is a field where you can serve so much, you can do so much good, you can inspire people even outside of your patient panel with the power of your example and the power of your words. And we've seen so many clinicians do that during the COVID-19 pandemic. So this is why, I feel very deeply and strongly about this subject. So you've already seen some work the federal government has done, but this is certainly just the beginning and not the end of what we will continue to do over the next few months and next couple of years.
Well, that's an inspiration we share. And, you can't overstate what a human tragedy the pandemic's been. But as you pointed out earlier, Vivek, the scientific advances and technological breakthroughs, the repurposing of drugs, moved at an astounding rate. And yet, we didn't do that well as a nation, although the science moved forward well. There'll probably be another pandemic in the 21st century at some point. What did we learn outside of the scientific area that we could take forward to better handle another pandemic in the 21st century?
Yeah, it is the right question to ask because we can't let this happen again, what we went through with COVID-19. And we know other pathogens will come. We just have to be better equipped to address them without sustaining this loss of life and the other costs that we've incurred. I think there are a number of things that we've got to do to prepare for the next pandemic. I think one of them is that we've got to recognize that public health infrastructure really matters. And we have dramatically underinvested over the last several decades in our public health infrastructure. Many of you may be aware that when the Great Recession struck, in 2008, 2009, funding for public health departments was dramatically slashed. And when the economy recovered, many of those public health departments didn't recover funding. They stayed at the low levels that they had. And so you have far too many public health departments that are working on the front lines of a pandemic with outdated equipment, without the staff they need, without the training that those staff deserve. And yet we rely on those local departments of public health to do everything from contact tracing, to help do testing, to help do public education on vaccines at a local level. So public health infrastructure is a place where we need to invest. Now with the ARP, we've made a huge investment in billions and billions of dollars in public health infrastructure, but we've got to sustain these investments over time. America cannot afford to fund itself one crisis at a time. Public health doesn't work that way. We've got to make investments for the long game. A few other areas where we really need to focus on as well. There's the science, of course, of developing vaccines and therapeutics, which is incredibly important. But there's also then the manufacturing and distribution. And one of the things that we've seen is that we really need more manufacturing capacity to be able to rapidly increase our production of vaccines and therapeutics when they're needed, not just for the United States, but for the world. And COVID has been just an incredibly poignant example of how our fate is deeply tied in to what happens in the country, which is why we have to lead and accelerate our work, continue to accelerate our work when it comes to helping vaccinate the world. So we've got to invest there as well. I think the third thing we've got to recognize, though, is that partnerships really matter here. Like the federal government can't solve this on its own. You can't leave it up to states entirely to just manage on their own. We have to have a really tight network between local, state, and federal government, but also with healthcare institutions, with doctors and nurses and health professionals across the country. We saw, for example, we're seeing this right now, that during a time where there is a profound challenge of vaccinating the 70 million people who remain unvaccinated, the people who are most trusted are actually people's doctors and nurses and healthcare professionals, right? Yet without a strong partnership between government and practitioners on the ground, it's hard to bring clinicians into that process to the extent that they need to be brought in, and hard to support them to the fullest extent that they need. So as a country, to battle the next pandemic, we will need our frontline clinicians, not just to deliver care, but to help communicate to the public. And that means we got to build those partnerships now. Best times to build partnerships are not during a crisis, they're before the crisis actually hits. The last thing I'll say, Jim, in terms of pandemic preparation, has to do with how we guard and steel ourselves against the onslaught of misinformation. We are seeing that everywhere right now. Misinformation spread rampantly on social media, through text-based channels, through other tools, and it is literally costing people their lives. I don't have to say this to the folks on the call here, because you're all living, right? You're seeing, your patient population, the myths and misinformation that people come in with. You're likely hearing it after you come home from clinic and the hospital, from family and friends. I certainly get plenty of questions from family and friends who tell me, hey, I got this video on WhatsApp. Is this true? And it's usually some false claim about the COVID-19 vaccines. And then I have to tell them, hey, that's actually not based in science or truth. So you know what this is like. But what is different about this misinformation now, Jim, compared to 10 years ago or 15 years ago, is really the speed and the scale and the sophistication with which which it is rapidly spreading. And it is making all of our jobs harder. It's costing people our lives. And part of how we need to address that involves, frankly, holding technology companies accountable for what happens on their sites, right? And accountable for making their sites a low-risk place where misinformation doesn't spread rampantly. We know that misinformation is much, much more likely to be shared than accurate information online. And we also know that the algorithms that many of the social media platforms use, ironically, amplify misinformation. If you encounter a piece of misinformation that, about, let's say, the COVID-19 vaccine, some of these algorithms will just continue to serve up more of that information because they saw that you interacted with it, which further deepens your doubts, about things that are proven to be true. This is actually one of the reasons why in July of this summer, I issued the Surgeon General's advisory on the health risks of health misinformation, with calling not only technology companies, but other sectors to account, but recognizing tech companies have an extraordinarily important role that they have to step up and play. They've been taking some steps to reduce the flow of misinformation, but it has not been nearly enough. And I have told several of them in my conversations that if I was running a hospital, and if I was successfully treating pneumonia and cellulitis and treating people when they came in for MIs or other health conditions, but I had a very high rate of DVTs because I wasn't prophylaxing people adequately. And I also had a high rate of surgical site infections, and there were a lot of line infections in the hospital. But I told you, hey, don't worry about all of those safety issues. Focus on the fact that I'm treating some illness as well. You would say that's not reasonable. You've got to not only provide care, you've got to provide safe care and make sure the hospital is a safe place. And I think the same principle applies here. Social media companies, I believe, have a moral obligation to make sure that their sites are not causing harm to people's health. And one of the clearest ways we're seeing that happen is through the rampant, unchecked spread of health misinformation on these sites. That's got to change. And that's why we issued our report. It's why we're continuing to press the companies to step up and fulfill what I think is their moral obligation to the public.
Well, it is such a huge problem, and I don't want to be overstating things, but I worry that it seeps into society at large because I noticed earlier this week the announcement of this year's Nobel in Physiology or Medicine didn't make it was in the papers a few pages back, but didn't make the front page columns of our major papers as typically, as I recall, it does. And so is that signaling, seeping into the general society, which, as you point out, is a huge problem. We have a couple minutes left until we have some Q&A from the audience. So I'd like to shift to the personal, if you don't mind. You entered as Surgeon General in the Obama administration. I'm sure you had a content knowledge of that general sphere of influence, but the fact is you hadn't done it before. Now you enter in the Biden administration as someone who's actually done it before. Your first day must be very different than your first day in the Obama administration. Could you talk a little bit about the uniqueness of this experience?
Well, thanks, Jim. I never dreamed I would have an opportunity to serve once, and certainly not twice. And it has been just such an incredible privilege, especially to be able to do it during this pandemic, a time where I spent much of the last year, like everybody else, with my life turned upside down, but wondering how I could be helpful, and feeling so often that I wasn't doing as much as I wanted to do to be of service. And when the president asked for me to serve in this position during the pandemic, specifically to focus on COVID-19, it was a gift and an opportunity to be able to hopefully do some good. My wife and I, thought about it because whenever you serve in government, it's a big change, from the life you lead before, and we had certainly found that out the first time. But it was an easy decision to make. I thought often, Jim, about the fact that in 5 years, in 10 years, my children, who are 3 and 5 now, will be reading about COVID-19 in their history books. They'll be studying this in school. And they were going to ask my wife and I, Mama, Papa, what did you do during this pandemic to help? I want to be able to tell them that we did everything that we possibly could. And for us, whatever was needed in terms of sacrifices, changes, relocations, whatever, to make sure we could serve and that capacity is what we did. It made it a lot easier actually for me to do this role having done it before. It's not to say that it's easy, it's always been a hard job and it continues to be a tough job, but I'm grateful to at least have understood the roles, what it can do well, what its limitations are, to understand how government works, and it works quite differently than the private sector, and how to build the right partnerships internally. A lot of that was incredibly helpful in enabling me to start, from sort of a fast pace right away, as opposed to taking 6 to 12 months to get up to speed. Now, I'll lastly just say this, Jim, on a personal note. I look at, a lot of the people we've hired into our office, are people like me. Either they or their parents or 2 generations ago came to this country, without much in the way of resources, but with high hopes. Or they're people who have been here for generations and generations, but didn't necessarily come from backgrounds of privilege. And I think of so many of us as a band of improbables, people whose history and whose ancestry, didn't necessarily make it the most likely thing that we would end up serving in government in a position where we could really make a difference. But I'm the same. My parents came here when I was 3 years old to the United States. They didn't have a lot of money. They didn't have any connections here, but they came driven by what so many immigrants are driven by, a desire to find a home that would provide better opportunities for their children. And I'm blessed that they found that, even though our life was challenging at times growing up, even though we encountered our fair share of racism and discrimination based on the color of our skin and the fact that we had funny sounding names, that we came from a country that not many people understood. Despite all of that, we were blessed to find teachers in public schools in Miami, Florida, who looked out for me and my sister. I was blessed to find mentors in medical school who helped inspire me to continue on that path, to serve, and who reminded me that this is a good profession. I was most of all blessed to have parents who built a medical practice when I was growing up that provided my first inspiration for what medicine could be, not just because of the science of medicine, but most importantly, because of the relationships that you could build with patients and the richness that you could not only deliver in terms of care, but experience through those relationships. All of this was very unlikely for me, Jim, because just a generation before that, my grandfather, my dad's dad, was a poor farmer in a small village in India. His wife died from TB, my paternal grandmother, when my dad was 10. And they were so poor that they spent nights around the dinner table adding more and more water to the bowl of grain or dal that they had, just so they had enough to fill each child's bowl around the table. That's how poor and they were, how difficult circumstances were. Yet somehow, because of the gift of America and the grace of God, my father was able to make it out of the village, get a training in medicine, find a home in the United States, find people here who supported his family morally and emotionally. And my parents were able to come in 2015 to see me inaugurated as Surgeon General. There are few places in the world where the grandson of a poor farmer from India could be asked by the president to look out for the health of an entire nation. But that is the extraordinary power and promise of America, and I will always be grateful for it.
Well, Vivek, what a fascinating and I have to say inspiring conversation. And I can't believe how fast this 35 minutes flew past. We're now going to have a Q&A with the audience. And since Michael Tutty is on site, we're going to shift to him to handle the Q&A since I'm virtual.
And great discussion. We're going to try to pivot and take a few questions from our folks who are watching online, and we'll take some from the audience as they come up to the mic. But we'll first take a question that has come from online. Vivek and Jim, the question is, are there any thoughts on requiring healthcare systems to screen for physician burnout? We know that which gets measured gets done, and with clinician well-being making such a dramatic difference in patient outcomes, doesn't this make sense? So the question is, should we be requiring health systems to screen for physician burnout?
Well, I'll just say that we have a business approach to that in taking a tool co-developed by the AMA and Harvard Business School that measures the economic impact of burnout in an institution so that the C-suite can see what this is actually costing them in bottom line, top line, and we're having some engagement there. In terms of a national requirement, it'd be interesting to hear what Vivek has to say.
Well, I think this is a really important question. I think many of us in medical school encountered that old adage that if you don't measure it, it doesn't matter. And so measuring clinician well-being and having appropriate tools for measurement is incredibly important. And part of what we are looking at inside is how do we create the right settings, the right incentives, the right hooks, if you will, to ensure that that measurement happens. So, I hope there'll be more to say on that in the near term, but I think it's a very important question. And I'm also a very firm believer that without measuring these outcomes, we can't hold ourselves accountable. We can't tell how difficult the problem is. And we also don't know when our interventions work, right? We're just operating with hope rather than with data. And so I'm a believer this data really matters. And so we are certainly looking at ways to ensure that appropriate development is put in place, but that those data collections actually happen, and that they're ideally done in as transparent a way as possible.
Great. We're going to take a question from the room to my left.
Good morning, Admiral. Thank you for your presentation. I would like to express gratitude.
Jim, I would say, unfortunately, I can't hear. I don't know if you're able to hear, but perhaps if Mike, if you can speak up, that'd be great.
I'm very close. Is that better?
Much better.
Okay. Well, good morning, good afternoon, whatever time zone you are in, Admiral. I would like to offer an expression of gratitude for your steadiness, your projection of calm since you have been Surgeon General. And that is so important in this crazy COVID calamitous crisis that we have. And how important it is that patients will remember how you made them feel long after you did what you did for them or what we have done as physicians. And then finally, I would like to say we have not had, at least in my experience, the steadiness that you project since Surgeon General Koop many years ago. And then finally, I would like to remind everyone that Dr. Fauci closes a circle that began with AIDS, HIV in the 80s, and now he's doing this for us now. And he too was an admiral. So thank you.
That is so kind of you. I deeply appreciate the very thoughtful words. And I will also share the admiration for Dr. Fauci. He's a good friend and a colleague, and I'm grateful to have a chance to work with him today. But the truth is, I will tell you that what I try to do each day, what he does and other colleagues of ours in the administration, is to frankly try to do what so many of you do each day with patients, right? Which is in the face of great adversity and uncertainty, we try to take a deep breath, and we try to stay with the people we are seeking to help, try to be as open as we can about what we know and what we don't know, but then commit ourselves to working as hard as we can to fill in the gap. And some days are better than others, and I certainly have many things I think of each day at the end of the day that I could have done better. That'll continue to be the case. But I feel the way in this job as I did as I was caring for patients over the years, which is just an incredible sense of privilege and being able to do this work and being able to participate in meaningful work in providing care to people, whether it's one-on-one or at scale. It does feel like a blessing to be able to do this work. It's what I saw as a 7-year-old child sitting in my parents' medical clinic, their family practice, so many days, after school as a child. And it's what I feel blessed to experience right now. And so thank you. Thank you for those words.
I think we'll take another question from, are we going to take another one from virtual? All right, we'll take another question from those who are online, from Sherry Schumann.
Sorry, it seems like I'm losing you again.
Yes, let me speak up. Here's the question from those online. Can you hear me okay? CMS and private insurance companies significantly add to the burden of physicians with increased regulation, prior authorization, and documentation. How can we address this pressure for the primary care physician?
Well, it's a really important question, and I will say my first exposure to the administrative burdens that primary care doctors experience was long before I went to medical school. It's actually sitting in my parents' primary care clinic and helping them go through the mail, and just seeing just how much of their time over the years increasingly became spent with papers and with computers rather than with patients and their families. And I saw the toll it took on them and how it impacted their feelings about patient care and how it contributed to their sense of burnout. And then later as a doctor, I came to see that as well. And this is where I think part of our national strategy to address clinician well-being has to focus on administrative simplification, and payers have a really important role to play here. There has been a proliferation of prior authorizations over the years, and I understand the reasons for some of them, but I don't think we account for the burden that they place on clinicians as well when we put these into place. It's, whenever you put a law in place, for example, in general government, you think about the financial cost, of that law. You think about that with rulemaking as well. But there's a human cost to this as well that I think we have vastly underestimated in terms of impact, not just on the clinician, but in terms of available face time with patients. So rethinking and reworking, re-examining the choices we make, and that includes payers, government, and private payers, is part of what we've got to do as part of our broader campaign and an initiative, I would say, on clinician well-being. So I'm glad you raised it. It's got to be a key part of the strategy, and it is the way I'm thinking about it right now. And we'll continue to focus on that because quality of the work matters. This isn't all just training people in resilience. It's making sure that people can focus less of their time on paperwork and administrative burden and more of their time on having conversations with patients and doing the work that it takes to make their care better.
Thank you. We'll take a question from in the room here to my right.
Dr. Murthy, thank you for having this discussion with us and being so insightful around physician and health caring professional well-being. I'm going to ask you a question that's probably in your wheelhouse around togetherness. We as physicians and health caring professionals have experienced a lot of things that contribute to our burnout. And now we're experiencing another one, and that is the healthcare communities and the communities that we live in are more divisive than we've ever experienced in our lives. So how can we as physicians, as health caring professionals, as physician leaders, gather the healthcare community and bring them together, and our communities and bring them together, that we are all fighting this together, that we're here to help each other and support each other and not to be divided. So thank you for your response in advance.
What a wonderful question, and thank you for it. And thank you for touching on something that we actually have not dug into today, but which I think is at the heart of our recovery from COVID and at the heart of what we need to do to address burnout, and that is building stronger social connection, social cohesion in our communities. One of the things that I learned, and I learned this the hard way, was just how profound an impact loneliness and social isolation have on our health and well-being. This includes on our mental health in terms of our predisposition and risk of anxiety and depression, but also the impact it has on physical health outcomes, including risk of cardiovascular disease, sleep disturbances, the list goes on. But one of the things that has concerned me deeply is that even before the pandemic, our rates of loneliness and isolation were quite high in the United States, and they were quite high in the medical profession, which seems counterintuitive to many people in the public who think, well, aren't doctors surrounded by people all day long? Aren't they taking care of patients day in and day out? But that in and of itself does not shield you entirely from loneliness and isolation. But when you are burned out at work, That makes it harder to emotionally connect with other people, whether they're at work or whether that's your family. That can lead to a greater sense of isolation. But we also know that connections at work can be incredibly healing. You know, I went to I went to an internal medicine residency program at Brigham and Women's Hospital that was not known for being easy. You know, we worked long hours just like everyone else. Like, their work was intense, and patients were often very sick. But one thing about it that I loved was that we had a powerful sense of community in the medicine program. People took care of each other. They looked out for each other. They would cover people's shifts even if they knew they weren't going to get paid back, because they knew that all of us can only get through this experience of internship and residency together, supporting one another. And that's why, like, even though internship was brutal and hard in so many ways, I felt like I was coming to work with friends each day. And that made it sustainable, but also really enjoyable. The question I think about so often is, what happens when you leave training? That it becomes a period of huge risk of isolation for many clinicians, who then go out without a built-in sense of community, whether that's in the practices they're working in or the hospital systems that they're operating in. And it can become very lonely very fast. And so part of, I think, what we need to do as we think about how to address burnout and enhance well-being is to think about the role of community in the profession. How do we foster it? How do we support it? How do we see it not as a nice to have, but as a necessary? And then how does that influence how we structure the time that clinicians have with each other, how we use time in the work setting for people to get to know one another? I will tell you, and then we could talk about this for the whole hour, but there are little things that you can do that don't take much time in a work setting that can help really strengthen dramatically the connections and bonds between people. We've actually done some of that in the Office of the Surgeon General. This is an area, also another priority area that we're looking to work on more broadly for the country, how to strengthen connection and community. But I'll say one last thing here, which is the last point you brought up, is about what's happening outside the healthcare community, right? The division and polarization that we are seeing in our society is what I believe threatens our health and well-being the most. Because it is incredibly difficult to get through a pandemic or any major adversity when a group is splintered, when people are turning against one another. And that's what we're seeing. There could not be a more important time for people to hear the healing and calming voices of physicians and healthcare providers in their community. And I mean hear it not just in the exam room, but to hear it in the public square. I so often wish that it was the voice of our colleagues that I was hearing in school board meetings, in town hall meetings, speaking to people in churches and synagogues, at town halls where people are trying to get together and understand what this pandemic is about. I found in my experience doing advocacy work that our colleagues in medicine dramatically underestimate how much people want to hear from them out in the broader community. They underestimate the power of their voice. And the values and ethics that we have been trained with in medicine, to see people as human beings, not as a political ideology, to respect and value every life, even if it's a person whose background is different than ours, to seek to preserve and support every individual, regardless of whether we agree or disagree with them. Those are values that the entire country needs more than ever, and we need to speak to those values. So my belief is that the more we show up as clinicians in the public square and use our voice, that is not only calming to people, but it reminds people of the values that we need to bring to this moment. That could not be more important, because when we lose our values, we lose our way. And we have good values in our country. We've been built on good values. We have values that have led us through difficult times in the moment. We pulled together during World War II and came through as a nation for the entire world. After major disasters, including Hurricane Andrew in 1992, one that I lived through in Miami, Florida, communities pulled together, the whole nation pulled together to support those communities. So we can't forget that that's who we are during our most difficult moments. And even though this has gone on, this pandemic, for so long, that it's led to frustration and to people turning against each other, even though it's been politicized in ways that have further deepened our divisions, we can't let that define who we are, how our communities operate, how we treat each other. And your voices in the public square can be powerful, powerful reminders of that.
That's great. Thank you. We'll take a question from those who are following along virtually. Given the parallel pandemic of physician suicide and the many factors that threaten the licensing and credentialing of physicians who seek mental health care, how can we make national policy changes to truly care for our healthcare providers?
Well, that's an important question, and I've heard too many stories from clinicians over the years who have said that they were struggling with depression or with anxiety, but were scared to get help because they were worried that their medical license would be taken away. We should never have a circumstance where a clinician is afraid to come forward and seek help because of a concern that they will be punished for that. That is counter to how we approach patient care in general. And the fact that many of our colleagues don't feel comfortable coming forward to me is a tragedy. It means that we have done something wrong. And part of the clinician well-being strategy that we have actually been working on includes a component around regulation and licensing in terms of thinking about the recommendations and rules that we need to have to ensure that every clinician is entitled to be able to bring up their needs and to have those needs met for mental health care without fear that there will be retribution of some sort or that they will be punished. That's not to say that there aren't circumstances that arise where, as a profession, we have to question someone's fitness for service, if you will, in medicine. We have to ask if a person is still, if it's still appropriate for that to have a license. But those tend to be in circumstances where somebody's judgment is severely impaired, where somebody may have, sort of demonstrated through their actions, or things that they have said, that they can't be trusted to deliver care at the standards that we all think are important. But that is different from allowing people to step forward and say, I need help, and to get that help. So we can't deny the same care to our fellow colleagues in medicine that we would fight for our patients. And that's why that's a part of the strategy we are putting together as well. It's really, really important.
Thank you. We'll take another question from inside the room to my left.
Great, thank you. Dr. Murthy, thank you again for being such a champion of physician well-being. I want to just return to the comments you made about the role that the federal government can have in advancing our platform here. So you mentioned strategy and that the government can be a convener. You also talked about dollars and perhaps even tapping into the role of payers. Arguably, the federal government already has convened and created that strategy through the work of the National Academy of Medicine's initiative. And now, thanks to the FEISTs and many others, there's research dollars pouring in. Hopefully, there will be a lot more. But I think tapping into payment on the role of the government is an area that's ripe and certainly hasn't been touched, in my opinion. I think, from where I sit, hospital system leaders understand that well-being is important, but they're being pulled in so many different directions, and so they're being incentivized in various ways. And we've seen the way payment reform has advanced the quality movement. What are your thoughts? What kind of political will would it take to leverage the role of the payer to advance clinician well-being?
Well, it's a very astute comment, and I do think that what you brought up there is a very powerful lever that we absolutely need to consider using as payers, and that is something that I've been discussing with colleagues in the building as well, because we've got to use every tool possible. Let me just say, though, to your point about the National Academy of Medicine, I'm a big fan of the National Academies. I work with them currently on issues related to clinician well-being, and have also had worked with them before. I was serving as Surgeon General this time around. And they've done a lot of tremendous work with the assistance and support and leadership of a number of people who are on this call right now, in making sure that we have so many of the building blocks that we need for a strategy. But what we want to do is to build on that and to further develop a strategy that we can then bring to the entire nation. And to get to a point I was making earlier, this can't just be a strategy that is understood and is familiar to a few leading healthcare systems and major medical organizations. We have to have public buy-in to this process. We have to build that, because that public buy-in will drive policy action, will make it sustainable for government and the private sector to continue down this path. It will also lead to calls for accountability, which is what we need. What I would hate to see is a flurry of activity over the next few months that ends up dying in a year or two because everyone's moved on to the next issue. We cannot afford to have that. Without a doubt, what we are doing is building on the great work that the National Academies of Medicine has done. Victor Zhao, who many of you know, and I know Jim has worked with over the years, is a huge champion of this issue. He's been a great partner and friend for me on this issue as well. We will continue to work collaboratively with them, but my goal is to figure out how do we continue to build out a really comprehensive national strategy and then launch that to the entire nation so that we have buy-in, we have this foundation for sustained action, and we have metrics and tools to hold ourselves accountable. So that long after you and I are gone and off the scene here, there will be ongoing action to protect and promote the well-being of our clinicians.
All right, I think we have time for one more question we'll take from in the room. Dr. Libby.
Thank you, Michael. And I echo the appreciation for you taking your time and giving us your insights and expertise on all these issues. And this may be a little bit of a different angle, but so much of what we do to offset the stress that we experience as practicing physicians is to find a lower level of staff to take on those responsibilities. They are usually minimum wage.
Could you just repeat that last line? I'm losing you again for some reason.
Okay, so much of what we do in practice to relieve ourselves of the burden of burnout is to offset many of those responsibilities and activities onto lower level staff. So our nurses, our MAs, our other kinds of ancillary providers end up providing a huge amount of that relief for us, yet they are experiencing burnout. They are experiencing a lot more social determinant stress themselves, many of them in many situations where there is inadequate support for them. And as a practitioner, as a physician in practice, I can't find staff anymore. We've seen hospitals close wings because they don't have nurses to provide the care. What can we do? What do you think we need to do as a nation to improve that ancillary, that support staff that creates all of the work that we order them to do and gives us the opportunity to be effective as clinicians?
Well, it's what you're describing is a really profound challenge, especially right now. And we've heard actually from a number of clinicians around the country that much of the staffing in terms of nursing and medical assistants, the pool of talent that they would draw from is now being pulled into hospitals as COVID-19 surges, creating increased demand for staffing in those settings. So this is undoubtedly a tougher situation for outpatient centers. Look, there's sort of near-term solutions, but then there's, I think, a longer-term set of solutions we have to look to. I think in the near term, one of the things that we've been doing from the federal government side is actually sending federal staff, including members of the U.S. Public Health Service Commission Corps that I oversee, to help support healthcare systems directly, providing doctors, nurses, pharmacists, physical therapists, other healthcare professionals who are on the front lines to try to decompress those systems, with the hope that providing some staff there can also help offset staffing shortages further out in the outpatient centers. But we also know that when it comes to the longer term, that one of the challenges that we've got to think about in terms of pandemic preparedness is how to have a greater reserve in terms of medical staff. Like we have, for example, many retired clinicians, nurses, doctors, and others in the country. And in earlier parts of the pandemic, there was discussion about how do we mobilize those retired clinicians to actually come back to the workforce at a time where we really need them. Many were willing to, many were able to, but they didn't quite know how to operationalize it, where to sign up, what to do. So I think we need much better systems in terms of pandemic preparedness to actually bring in so much of the skilled labor, if you will, that's on the sidelines. People who either retired, people who are working part-time and don't necessarily know that they're needed more than that. We need to be able to bring them more quickly into the system. There's another thing that we are doing also within the Public Health Service Commission Corps, which is we are looking at building a broader reserve, if you will, called our Ready Reserve, which is our cadre. And I should just step back and tell you that the U.S. Public Health Service Commission Corps, which the Surgeon General oversees, is one of the 8 uniformed services in the U.S. government. It consists of 6,000 uniformed healthcare professionals, that include doctors and nurses, physical therapists, pharmacists, PAs, a whole range of healthcare providers. And we deploy them around the country during times of urgent need. Many, we deployed thousands for COVID-19. We've also deployed many officers during hurricanes, tornadoes, 9/11, for the Ebola outbreak in West Africa, et cetera. So that's what the core is. But we are also in the process now of building something called the Ready Reserve, which will be a group of officers who are not full-time in the federal government, but who are around the country and can be strategically pulled and deployed to parts of the country where there are great need, and to do this in much greater capacity than exists right now in the federal government. And our hope is that if we can help allay some of the workforce pressure that tertiary systems are facing right now, and that we can actually help reduce some of the shortages that downstream primary care practices and other outpatient practices are seeing. So to me, this is workforce is part of pandemic preparedness. It's what we've got to think about and do in the longer term. The short term, unfortunately, is really tough, and we're trying to augment with as much federal personnel as we can. But this also just highlights why it's so important for us to get people vaccinated as quickly as possible. That is where key to so much of getting through the pandemic, but it is also what will help reduce the number of people who are in our hospitals, because we know still the vast majority of hospitalized COVID patients are unvaccinated. If we do that, we will reduce the burden on the healthcare system. We will actually free up more of our workforce, and we will have less of a pinch in our outpatient centers around the country.
Thank you. Jim, I'll throw it back to you to close out the session.
Well, thanks very much. And I want to thank Vivek, Dr. General, for joining us today. In the beginning of this, in the introduction, I said that I thought we were in for a really interesting and insightful conversation. And to that, we can now add inspiring. So thank you for that. And we look forward to working with you. And we would love to help each other be successful in the vision that you've laid out today. Thanks again.
Well, thank you so much, Jim. I think you and everyone who is at this conference who cares deeply about the issue of clinician well-being and burnout. I just want to thank you for being here. Thank you for what you're doing each and every day to help care for patients around the country. Speaking of inspiration, it is all of you who inspire, not just me, but you're inspiring millions of people around the country. You're inspiring a lot of my colleagues in government. And we talk to them a lot about the stories that we hear from the front lines. The earliest days when I was advising President Biden last year on COVID-19, I would tell him stories that I was hearing from colleagues about what they were encountering on the front lines, but also what they were enduring in order to be able to show up each and every day for work. The doctors who were living in their basements so they wouldn't expose their family, but still ensuring that they could go to work. Those clinicians who were working 16, 17, 18 hours a day because the need was so great. He and so many others in the administration and government more broadly are deeply respectful and appreciative of what you do, as they should be, because you truly are providing so much of what the country needs in terms of care, but also in terms of inspiration. So thank you for what you do. I will look forward also, Jim, to working with you on addressing clinician burnout. This is a huge priority. It is a moral imperative, I believe, for us to address as a country, and we will do that together.
Thanks very much.
Take care.